Good morning, everyone, and welcome to Caffeinate and Innovate, where we chat with leading experts in prevention science. These 30-minute sessions are designed to wake up your creativity and help you think outside the box. If you have any questions as we go along today, feel free to drop it in the Q&A at any time during the session. And if you'd rather ask your question out loud, we will have some time at the end where you can unmute and jump into the conversation. If I don't get to every question, I will send a follow-up with Alex's responses after today's session. Good morning, Alex, and welcome. It's great to have you here.
Sure. Yeah. So my name's Alex Elswick. I'm born and raised here in Lexington, Kentucky, reporting live from sunny Lexington. Um, I'm just a person who's been fortunate to learn about drugs and people who use drugs from lots of different experiences. So I'm a person in recovery myself from an opioid use disorder, and I'm a assistant professor at the University of Kentucky, where I teach and do research on recovery from substance use disorder. And then I'm a co-founder of one of the first and one of the largest recovery community organizations in the country called Voices of Hope. So we have about 85 staff who are all people who use lived experience in recovery to build rapport with others and help other people access services. Good morning.
To,
Thanks for having me.
yeah. To get started, can you tell us just a little bit about yourself? That's awesome. Sounds like you're busy. You do a lot. So I know that we won't get to cover everything that you're working on, but it sounds like your primary goal is meeting people where they're at in their addiction and recovery journey. Can you tell us about some of the strategies that you use to do this?
Yes, that's such a great place to start. And so my favorite way to kind of help center us in this conversation is to give an analogy that's a little bit more accessible to people, which is from sex education. Maybe a little bit uncomfortable for this early in the morning, but for decades and decades, we incorporated abstinence-based sex education that was really focused on just teaching kids not to have sex and teaching them about the harms associated with sex, teaching them, showing pictures of STIs um, and it really had limited efficacy. And what we found is that it's really an uncomfortable fact that some adolescents were having sex, and despite our best efforts, and uncomfortable certainly, but a fact nevertheless, that we had to, a reality with which we had to contend. And so in many ways, we're talking about the same thing for drugs and drug use that we've tried for so long, this abstinence only approach. And it's an uncomfortable fact, uncomfortable, yes, but a fact nonetheless, that some people use drugs, and a reality with which we have to contend. And so these other approaches really focus less on coercing abstinence and more on helping people kind of autonomously find a pathway of recovery that works for them.
Awesome. So, how does the use of these strategies differ from the traditional approach to prevention and recovery?
So the traditional, I guess, kind of one-dimensional abstinence-only approach um, is it requires people to be in a very unique, a very specific place in order to be prepared for recovery, a very specific place in the stages of change where they say, yes, I'm ready, able, and willing not only to be abstinent, but to be abstinent perfectly, to be abstinent starting today, probably to suspend my life for 30 days, to leave my job for 30 days, to leave my family for 30 days. It's just an incredible expectation, a really lofty, steep expectation. And so this kind of alternative approach, maybe I'll tell you a story to make a little more sense. We have our Recovery Community Center is on Broadway in Lexington, Kentucky, and our sign out front says Recovery Community Center. But to so many people in my community, the word recovery just means abstinence. And so we had a woman in our community who was experiencing homelessness, and she's pushing a shop. I mean, this sounds like a contrived story, but I just promise you it's true. She's pushing a shopping cart out in front of our center every single day. She's a person who uses drugs intravenously. But every time she sees our sign, she sees Recovery Community Center, and in her head, she hears Abstinence Center. And so she thinks to herself, like, that's not for me. For a variety of complicated reasons, I'm just not in a place where I'm prepared for abstinence right now. My goodness, I don't have a home. And so day after day, she just pushes her cart by and pushes her cart by. And then one day, just randomly through word of mouth, she heard from one of our other participants that she could get her laundry done for free at Voices of Hope. We have a washer and a dryer that we offer to participants, super low barrier. All they have to do is chat with a recovery coach. That doesn't mean commit to going to treatment, commit to any kind of behavior change. It means you say, how's your day going today? And so I promise I'm wrapping the story up. It's going somewhere. The first week she comes in to do her laundry, there's a chair right next to the washer and dryer, and she never leaves the chair. And she sits right there with her phone plugged up charging, and she plays on her phone and doesn't leave. The second week she comes in, she puts her clothes in the laundry, and she goes and gets a cup of coffee and wanders around a bit. And on the third week, she puts her clothes in the laundry. She gets a cup of coffee. She starts interacting and she goes out back to our smoking pad to smoke a cigarette. And out of the clear blue sky, she looks at our recovery coach and she says, "Hey, if I wanted to get into treatment, could you get me into treatment?" And our recovery coach is like, "Well, I'll have you in treatment in an hour if that's what you want." And so, just to summarize, the reason I love that story, that individual is more than 2 years in recovery. Ironically enough, she's more than 2 years in completely abstinence-based recovery. And I think the reason this is such a good exemplar story is because it shows that if, like everyone else, like the traditional approach, if we'd only been preoccupied with coercing her into abstinence in the beginning, she probably wouldn't be abstinent today. She'd probably still be under a bridge, right? But it's really because we take this other approach that's much more comprehensive, that focuses a lot more on building a relationship first, that we were able to put her in a position to start a kind of recovery that works for her.
That is amazing and very, very empowering story. So are these are, are these supportive interventions? Obviously, they're not the opposite of recovery. Can you talk a little bit how those are related and can be related? Obviously, we saw that in this particular story. Are there any other examples or any more information that you can give on that?
Well, it's a great question. And my colleague and one of our co-founders at Voices of Hope, who's also a professor at UK, Dr. Fallon Bennett, and I talk about this a lot, that in the field, in the discipline, a lot of times we talk about recovery and more of a risk reduction focus as if they're really kind of opposite strategies. But just looking at them in terms, the way that SAMHSA defines recovery is as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. There's no mention of drug use. There's no mention of abstinence, even for the experts at SAMHSA defining recovery. And so I think these are actually two concepts that are married, either that conceptually are married together much more than we realize, and in practice need to be married together much more than we realize, so that individuals like the woman I described have a pathway to recovery, instead of saying, "Hey, come to us when you're ready to get sober," which leaves so many people in that gap.
Yeah, yeah. So you mentioned the gap, and you're referring to the treatment gap. Can you explain what that is and why it's important?
Yes, this is such incredibly important context, and it's something I didn't really understand for a long time. And I think it's the better that we understand the treatment gap, it really creates a paradigm shift, I think, for people in their understanding of addiction, treatment, and recovery. So the National Survey on Drug Use and Health, which is our big epidemiological survey of drug use and addiction, year after year, it shows somewhere between a 75 to 95% treatment gap, which means 3/4 to 95% of people who need treatment don't get it each year. And most people, when we hear that, we make an assumption, and it's a false assumption, that the treatment gap is a result of a lack of treatment availability or treatment accessibility. And so I don't know if you've ever heard of the three A's, but availability, accessibility, and acceptability. And so the reality is this is this is less a problem of treatment accept availability. The treatments exist. It's less a problem of treatment accessibility and more a problem of treatment availability. And what I mean by that is, if you ask those, let's say 3/4 to 95%, how come you didn't get treatment this year? The vast majority report that it's not because they couldn't access treatment. It's not because they experienced geographical or structural barriers to treatment. It's because they weren't interested in the treatment options that were available. And that's real. That statement alone needs a lot of unpacking, because it doesn't mean that people don't desire health and wellness. It doesn't mean that people don't desire positive change, but it means that for a lot of people, the bar of complete and perfect abstinence achieved by leaving my family for months at a time and ending my career, it might be too high of a bar. And so just to wrap that up, kind of put a point on it, I just think about people who struggle with weight loss. And if we said to people, hey, if you're not willing to lose 100 pounds, then you shouldn't even try. Then don't even start. Come back when you're ready to lose 100 pounds. It's such a ridiculous notion that incremental change is unacceptable.
Yeah, yeah, definitely puts it into perspective more. In that sense, what are some strategies that you're using for that incremental change that are different from what others are doing?
Yes. So, kind of thinking about those A's, availability, accessibility, and acceptability. So, in terms of accessibility, we're trying to improve access to some of these other evidence-based pathways of recovery. So, for instance, medications for opioid use disorder, buprenorphine, and even methadone and naltrexone, which have, these are pharmacotherapies that have really, really strong evidence base, but they're incredibly stigmatized. And as a result, something like a third of people who would benefit actually have the access that they need. And so, one of the ways that we're improving access is with transportation. We created a transportation program. And our drivers are peers in recovery, and they drive people to medical appointments, wraparound social services, but primarily to OTPs to access methadone. And recently, some of our colleagues published a paper, and it was titled something like "To the Moon and Back," because we've literally driven so many miles in this intervention that we could have driven to the moon and back, which I think is incredible testament to the work, but also to the incredible need that exists and the barriers that exist to those. And then one other thing I would say is, in terms of acceptability, we're also trying to shape attitudes, and that's attitudes among the general public, attitudes among providers, attitudes among people in recovery themselves who have kind of a one-dimensional understanding, through marketing campaigns and all sorts of different approaches.
Yeah, yeah. So leading into the next thing, you're kind of alluding to the single story narrative of addiction and recovery. Can you explain what that single story narrative is?
Yes. I'm so glad that this question was included because this is like really important context for the broader discussion that I think is very helpful. So, quickly, what is a single story narrative? Um, the best way to explain a single story narrative is by talking about Africa and the way that we think about Africa in the West. So in the Occident, in the West, we tell a single story of Africa. Africa is actually a continent with like 50 some countries and lots of different cultures and lots of different languages and identities. And yet, so often when we tell the story of Africa in the West, we just tell this single story of Africa as war torn and politically corrupt, et cetera, et cetera. So the same thing happens with addiction and recovery, where we tell this very unidimensional story. And the problem with single stories is not that they're untrue, it's that they're incomplete. And so we tell a single story about addiction and recovery that abstinence-based treatments, really, this is an important distinction. The single story of recovery is not only that abstinence-based treatment should be the way that most people recover, but the single story is also that abstinence-based treatment is the only way that people recover. And this is a narrative that we push in so many different respects that totally belies the data. It's like we're totally ignoring what the research has to say about that.
Yeah, that's that's very true. Um, so how is this single story narrative reinforced by people who use drugs, providers, and the general public?
Yes. And I say this as a person who is guilty of this sin myself in the beginning, and I think we all are to some extent, but I think it happens unintentionally for all of us. First of all, within, let's say, 12-step programs, just as an example, I was a member of a 12-step program, and within 12-step programs, you're actually given a boilerplate for how to understand and to tell your own story. And what that boilerplate causes, and there's some literature, some research to this effect, it causes a kind of conformity among people in the group to conform to a single story narrative. And to give you a more concrete example of what that looks like in my own life, I had an opioid use disorder. I struggled with addiction to opioids. I never had a problem with alcohol. But in 12-step spaces, I was instructed that if you have a problem with something, you'll have a problem with everything. And they told me that my story is that I have a problem with alcohol. And I came to learn that that's not true. I don't like to drink alcohol. It upsets my stomach. I choose not to drink it, but I don't have that problem. And so in that way, my experience didn't fit the single story narrative despite pressures to conform. So that's kind of within and among people who use drugs. But then among providers, one of the ways I saw the single story perpetuated, also unintentionally and in good faith, is that we only lift up examples of visible role models of people in recovery who are in abstinence-based recovery. And so for example, if nursing students are going to go and learn about a support group, they go to an abstinence-based AA meeting. If providers are going to invite someone with lived experience as a part of grand rounds to share their testimony, 99.9% of the time, it's going to be someone in abstinence-based recovery. And that's great and that's fine. That's a perfectly acceptable pathway of recovery, but it means we're not representing people who use medications for opioid use disorder, and we're not representing people who use this plethora of other pathways. And so those are just a couple of minor examples, but I think the broader point is that none of us are doing it intentionally. Because we're sort of unaware that this single story pressure exists, we're sort of all throughout our day unintentionally reinforcing this sort of false narrative.
Okay, yeah, I have a couple of follow-ups for that. So I'm going to start with, what are the consequences of this single story narrative?
Yes. They are many. So what the single story narrative does is it centers our understanding of addiction and recovery on abstinence rather than health and wellness. And that has some tremendous consequences. I think the simplest way to describe this, and this may come across as a little bit harsh, but I think it is the simplest way to say it, is right now in 2025, there are largely two camps of people. There are people who are shocked, horrified, and scandalized by the fact that so many people are dying of preventable overdose. That's one camp. And another camp is people who are shocked, horrified, and scandalized by the fact that people are using drugs. And I think the gap between the understanding of risk and harm that's happening to our communities between those two groups is vast. And so the consequence of this single story is it undermines all of these other efforts to reduce harms. So just, again, we've been using the example of medications for opioid use disorder. So often the narrative I hear, especially in rural parts of my state, is, well, that's not really recovery because you're just replacing one drug for another. And you're talking about a medication that reduces mortality by like 60%, right? So I always tell people, yeah, opinions be what they are. I'll just tell you this. I've probably passed along a lot of genetic risk for addiction to my own son. And if he, God forbid, experiences an opioid use disorder of his own, one of the first things I would do is put him on one of those pharmacotherapies in order to protect his life, right? So,
Yeah. So looking at that same vein and going back to what you were talking about prior, how can we tell these more honest stories of the diverse array of recovery experiences? Because it sounds like that is part of the solution here, is to share more of the honest stories and how it's different for different individuals.
I think in so many ways, the answer lies in the question there. You've asked just such a good question. We have to tell new stories. And it's, in CRT, it's called counter storytelling, but really all it means is we're just we're telling the truth. It's not like we're doing anything special or fancy. We're just representing these stories that haven't been represented. And by the way, just to reinforce why this is so important, it's because abstinence-based recovery is not the normative experience. So most of us assume that the majority of people in recovery got that way through pure abstinence, and that's not the normative experience. And so it's so important to kind of shift that paradigm and center us on people recover in a multitude of different ways. And I'm not the arbiter of what's good and bad recovery. I just want to see people get healthy and see people get well.
Yeah. Thank you, Alex. Okay, I have one last question for me, and then we have one question in our Q&A, and then I'll open it up to everybody else. So for everyone here listening today, what are some practical strategies that prevention professionals can take with them today to start implementing to kind of be part of the solution here?
Great question. And I think the first and most obvious to me for prevention professionals is overdose response training, to be instructed on rescue breathing and how to respond to an overdose, how to administer naloxone, to be encouraged to carry naloxone. It's a really good example of how reducing risk is not something we just do for people who use drugs or for people for whom abstinence hasn't been effective. It's across the entire spectrum, including for prevention professionals, including reducing risk for youth, and et cetera, et cetera. So um, have yourself trained in overdose response and naloxone administration. You can also bring that kind of training to your organization. That's a great thing to do. You can, as a part of that, I always think it's valuable to pair with the training a story of lived experience. And so this would be a great opportunity to tell a new story, to share an experience of someone who's used maybe a different pathway of recovery, in particular, maybe to tell the story of someone whose life has been saved with naloxone. There are many, many. About half of our staff at Voices of Hope have had an overdose reversed with naloxone. So it's about 40 people on our staff. And then the other thing I would say is continue to educate yourselves about all pathways, just as I do. I know sometimes I sound like finger pointing and or finger wagging and heavy handed, but it's just this for me. Coming to this epiphany about all pathways has been such a long journey and such a long experience. And I want to spread the gospel. I want to bring other people along. So
Awesome. Well, thank you so much, Alex. We have a couple of questions that came through our Q&A. The first one is, how do you address the stigma against medications for opioid use disorder in everyday life as well as in the professional field?
yes, great question. It's a tremendous stigma. There are a variety of different ways that I address the stigma. One of them is just by sharing that because there are really high rates of smoking still in my state, cigarette smoking. I used to smoke cigarettes. Um, and when I struggled to quit smoking cigarettes, I used nicotine replacement therapy. And there wasn't a single person who stigmatized me for that. There wasn't a single person who said to me, Alex, you're really just replacing one form of nicotine for another. What everyone said to me was, dude, I'm so proud of you. That's so much better for your health. That's such a good decision. Good for you. Maybe you'll quit using the gum. Maybe you won't. Who cares? Because really, nicotine itself isn't nearly as harmful as all those additional chemicals you were smoking. I use that as a little bit of just an analogy to say the same is true for people with opioid use disorder, many of whom have tried earnestly and ardently different types of abstinence-based treatments and to no avail, and who say, if I've tried this 10 or 12 times, maybe it makes sense for me to avail myself of a different evidence-based approach.
Thank you. We have one more question in the Q&A. How do you handle interactions with professionals that insist on promoting abstinence-based recovery? And in parentheses, they said, especially if they are your superior.
Yeah, it's really hard. It's especially among a lot of this recovery epidemiology that's allowed us to understand these multitude of pathways and understand non-abstinence is fairly recent. There's certainly like a foundation for it from decades ago, but a lot of it's fairly recent. And I say that to say so many of people in positions of power today in the addiction treatment community, in the medical community, in the academic community, whatever it is, were trained at a time when they didn't learn that. And so many of them are unaware of it. And that puts us, those of us who have been exposed to that in the unique position. And so I try to I'll tell you what I do, honestly. One of the taglines of a more risk reduction focused approach that Tess alluded to at the very beginning is meet people where they're at. And so not only do we do that with people who use drugs, but I also do that with my coworkers and with my superiors and with all the people I interact with, that their understanding of addiction and recovery and behavior change, they're on a journey just like I was. And it took me a good dozen years to arrive at this conclusion. And it's still changing every day. So it's probably not fair for me to expect someone else to come there in a year or whatever it is. So try to have grace for people, but I don't stop having these conversations and putting the data in front of them.
Yeah, okay, we just got we have a couple comments in the chat. We have one that came through earlier. Just an individual saying, it took me a long time to honor my brother for kicking meth and opioids because he still used alcohol and marijuana. So I think that's just a powerful thought. And then we also have a question or comment, I'm not sure. I see with a lot of adults addressing youth, again, the focus is on the fact that they're doing something illegal instead of focusing on the fact that they want to quit and they're just as addicted to a drug as an adult as an adult would be and need the same support instead of focusing on the shame of their decision to start. So they're saying focus should rather be on the fact that they want to do better and want to do less or no harm.
Yeah, and it just really quickly to comment on both. In the first case, people will, it's another pathway of recovery that people stigmatize. And so people will pejoratively talk about people who use cannabis in recovery as California sober. And it's a pejorative way of saying you're not really in recovery. And all I know to tell you from that is we have employees, I have so many friends, I have colleagues who are professionals for whom um, opioids caused a problem and they use cannabis or they use alcohol or they use whatever and they unproblematically, and you would have no idea. And part of the reason you have no idea is because they can't say it out loud because there's so much stigma, which creates this circular problem. It reinforces the single story. So I just say that to say thank you for sharing that experience, and God bless your brother for that pathway. And then to the second point, just in general, it's incredible how we continue to double down on punitive approaches. Just to put it simply, what defines addiction is continuing to engage in a behavior despite harmful consequences. So when you keep that in your mind, why on earth would our strategy be to continue to assert harmful consequences? It belies the definition of addiction. People are going to continue doing it despite the consequences, no matter how intensely you incarcerate them or kick them out of schools or wrap their hands with a ruler. So I think it's a good place to kind of wrap us up back to the beginning, which is it's an uncomfortable reality. Some people use drugs, and as a community, we have to decide how are we going to contend with that? Are we going to ignore it? Are we going to deny it? We going to condemn it? Or are we going to accept it as a reality and find ways to reduce harm for everyone?
Okay, I think that is all of our Q&A questions and our chat questions. Does anybody want to come off mute and you can ask questions, add to the conversation? If anything's on your mind, you can just go right ahead and unmute. We'd love to hear your thoughts and keep this conversation going for the last few minutes we have here.
I'm probably going to sound really naive or out of it here or whatever, but so I'm very thankful for your not only your information but your enthusiasm. And so I have been in prevention for over 20 years, and yes, peer support and harm reduction, those are all new concepts and stuff that I am really working to support and uh, really help initiate more in our community. And we have a good coalition who's doing so. I think part of that from that the one person's perspective of their brother quit meth and opioids, but then when we still see them use alcohol and marijuana, when we understand how the brain, especially with youth, how the brain is so easily addicted, and we know that that leads to further addictions throughout their lifetime. That's where that's kind of a fear, is that, yeah, so really helping people get beyond that fear. But and the hard thing is that when we know the science, the neuroscience of that addiction process throughout a lifetime, so it's really hard to separate those things out, isn't it? So yeah, that's a really difficult part of this whole process.
Yeah, Penny, I appreciate, first of all, your candor that you're like on a journey. Because, like I said, it's been a journey for me. If I had given this talk 10 years ago, I wouldn't have been able to. I wouldn't be having this discussion at all. So, number one, I just appreciate that, especially for somebody who's been in the field for a while. I know that a lot of it is new, and some of it's even kind of a little bit threatening because it kind of goes to the foundations of the things that we believe. So, I appreciate that. But also, just to clarify, in the example that we gave, I was assuming that her brother was an adult when he was using cannabis and alcohol rather than drugs. And I may have just misunderstood that, because I would totally agree with you, Penny. Really, when we're talking with youth and we're worried about young people, we're worried about drugs for a different reason because of what it does to their brains. We're always telling young people, yeah, we want you to say no to drugs, but that's not very likely, because the reality is about 60% of American adults use drugs when you consider nicotine and alcohol. I mean, this is called caffeinate and innovate. Caffeine's a drug. I heard today's National Tea Day. So, I mean, people use drugs, right? Then the question is, how do we like really try to delay drug use for young people? So I don't disagree with you. And by the way, it's always important to come back to, as a philosophy, harm reduction is about reducing harm. And so, there's always this tension between respecting autonomy and reducing harm. And there are places where those are really at odds. And So that's, we're not condoning drug use. We're not promoting drug use. It's nothing like that. And I know sometimes it feels like it's skirting that with how permissive and autonomous it can be. But anyways, appreciate your honesty, appreciate your journey. Just don't stop. Just keep asking questions and talking about it and learning, and keep admitting what doesn't make sense, because that's really for me what's helped. So appreciate you.
Thank you so much, Alex. We are all out of time. Thank you to everyone for your attendance and participation. We should have a slide coming up here that has a QR code for our next Caffeinate and Innovate session on June 18th, same time, 9 to 9:30 Central. We'll have it every third Wednesday of the month. And then if you can fill out the survey also, it should show up in your browser at the end of this also, but we have the link here on the slide as well as a QR code. And Megan, if you can throw that, thank you. She's one step ahead of me. So that link is also in the chat. Thank you everybody so much for your participation today.